Deep vein thrombosis, or DVT. It's one of those clinical challenges that you are absolutely going to face on the wards. So today, we're going to break it all down with a really practical guide to help you go from that first gut feeling of suspicion all the way to long-term patient care. So picture this. This is the classic scenario, right? A patient comes in with one leg that's swollen, red, and painful. Your mind should immediately start racing. DVT is way up high on that list for sure. But what else could be going on? This is really ground zero for our entire diagnostic journey. All right, here's our game plan. First, we'll nail down that classic presentation. Then we'll dive into the differential diagnosis. After that, we'll talk about how to confirm it, walk through the management playbook, and finally, look at what happens long-term, beyond the acute clot. Let's jump in. Okay, first things first. You can't diagnose something if you don't suspect it in the first place. So let's really sharpen our focus on those key signs that should make the alarm bells for DVT go off in your head. So you're on the lookout for the textbook signs. You know, one leg is bigger than the other, it's tender, warm to the touch, maybe a little reddish. But, and this is a huge but, here's the clinical pearl you gotta remember. About half of all patients with a DVT have zero symptoms. None. Their first sign might be a massive, life-threatening pulmonary embolism. That's why you've always got to have a high index of suspicion. So you've got that swollen leg right in front of you. And it is so tempting to get tunnel vision and just zero in on DVT. But a really sharp clinician always considers the mimics. There are a bunch of other conditions that can look just like a DVT, and we need to know how to tell them apart. This is probably the biggest head scratcher you'll face. Cellulitis, a skin infection, gives you redness, swelling, and warmth. So how do you tell them apart? Well, with cellulitis, that redness tends to spread pretty quickly, and a fever is a really common finding. With a DVT, a fever is pretty uncommon, and the pain is usually more of a deep ache that gets worse when they stand up. These are subtle clues, but they are absolutely critical. Okay, now this one is super important to get right. A DVT is a venous problem. Blood can't get out, so the leg gets congested, warm, and red. An acute arterial occlusion is the total opposite. Blood can't get in. That makes the leg cool, pale, and you might not even be able to find a pulse. Think of it this way. DVT is like a plumbing backup, but an arterial occlusion is like the main water line to the house being shut off completely. It's a true vascular emergency. And believe me, the list goes on. You could have a ruptured Beaker cyst behind the knee that spills fluid into the calf, causing sudden pain. Or it could be lymphedema, which is a problem with the lymphatic system, or even chronic venous stasis from poor blood return over time. This just drives home the point that we can't rely on the physical exam alone. We need a system. So we're suspicious. We've thought about what else it could be. Now let's talk about how we move from clinical suspicion to actually proving the diagnosis with some hard evidence. Before we go ordering a ton of tests on everyone, we need a way to quantify our suspicion. And that's exactly where a clinical prediction rule comes into play. You can think of it like a standardized scorecard that helps us combine all the risk factors and exam findings to get a better sense of how likely it is our patient actually has a DVT. And this is the Wells score. It's going to be your best friend in a DVT workup. You just run down this checklist. Does the patient have active cancer? Were they recently in a cast or stuck in bed? Is their whole leg swollen? You add up the points as you go, and check this out. The last item is interesting. If you think another diagnosis is just as likely, you actually subtract 2 points. If that final score is 2 or more, we say a DVT is likely, and that totally changes our next move. This algorithm is just everything. Think of it like a flowchart. If the Wells score is low, making a DVT unlikely, we start with a D-dimer test. It's super sensitive for clot breakdown products. If that D-dimer is negative, you're done. No DVT. But if the Wells score was high or likely, we skip the D-dimer entirely and go straight to a compression ultrasound. That's the gold standard. Oh, and if that unlikely patient has a positive D-dimer, they also get an ultrasound. It's a beautiful system for safely and efficiently ruling the diagnosis in or out. Okay, diagnosis is confirmed. We have a DVT. Now what? It's time to open up the management playbook. Our focus now shifts to treatment. And we've got 2 very clear goals: deal with the clot we have and prevent any really terrible complications down the road. And let's be super clear about the goal here. We're not just treating a sore leg. The #1 reason we treat a DVT is to stop that clot from getting any bigger and, most importantly, to prevent a piece of it from breaking off, traveling up to the lungs, and causing a potentially fatal pulmonary embolism. Anticoagulation, that is the cornerstone, the absolute foundation of DVT therapy. These drugs, these blood thinners, don't really dissolve the clot, but they stop it from growing and give your body's own clot-busting system, fibrinolysis, time to do its work. Our options range from injectables like low molecular weight heparin to the newer, easier direct oral anticoagulants, or DOACs. For a standard first-time DVT, you're typically looking at treatment for at least 3 months. Okay, so anticoagulation is the standard of care. But what if this isn't a standard DVT? What happens when you're dealing with a really massive clot up in the big iliac or femoral veins, causing a ton of pain and swelling? In those cases, just stopping the clot from growing might not be enough. This is where we have to consider some more aggressive, advanced options. And that brings us to something called catheter-directed thrombolysis, or CDT. This is where things get a bit more high-tech. Instead of just thinning the blood systemically, an interventional radiologist will actually thread a tiny catheter right up to the clot and drip a powerful clot-busting drug directly onto it. It can restore blood flow really fast, but it does come with a higher risk of bleeding, so picking the right patient is absolutely key. So what about those IVC filters you hear about? You know, the little metal cages they put in the big vein, the inferior vena cava, to catch clots. Here's the deal. They are absolutely not a first-line treatment. Their use is reserved for really specific situations, like a patient with a DVT who has a very high bleeding risk and just can't be on anticoagulants, or someone who keeps getting PEs even though they're on the right therapy. All right, so the patient is stable, the acute danger has passed, but our job as clinicians, it's not over, not by a long shot. Now we have to shift our focus to managing the long-term consequences of that DVT. Get ready for this number because it's a big one. Up to 50%. That's how many patients who have a DVT will go on to develop the most common long-term complication, post-thrombotic syndrome, or PTS. That number is just staggering, and it represents a huge, huge burden on their quality of life. So what does that actually feel like for the patient? Well, PTS is basically this chronic condition where the valves in the veins were damaged by the original clot. So patients live with daily leg pain, a feeling of heaviness, and swelling that gets worse when they're up and about. It's this constant nagging reminder of the DVT they had. So what can we do to help? Well, the management really boils down to improving their symptoms and function. Graduated compression stockings are a mainstay for relief. Exercise is actually crucial for strengthening the calf muscles, which helps pump blood back up. And simple patient education on things like elevating the leg, maintaining a healthy weight, and taking good care of their skin can make a real difference in their day-to-day life. But when you get right down to it, while we can manage the symptoms of PTS, the best strategy is always prevention. And the single most effective way to prevent post-thrombotic syndrome is to prevent another DVT. That comes down to good, consistent, appropriate long-term management. That's the real key. So I'll leave you with this thought. Treating the acute DVT, that's really just the first chapter. The story continues. The real challenge, and honestly where you can make the biggest difference, is in that long-term partnership with your patient, counseling them, making sure they stick with their therapy, and helping them recognize any warning signs. That's how we go from just treating a clot to truly protecting a person's future health and their quality of life.